We are recording. Go ahead.
Okay, good. Thanks, Patrick, and welcome everybody to our Monday seminar series, which is co-sponsored by the Global Public Health minor here at the University of Montana, the School of Public and Community Health Sciences, also at U of M, and the Institute for Health and Humanities. So my name is Kimberly McKay, and I'm the director of the Global Public Health program and a faculty member in the School of Public and Community Health Sciences. And I'm so pleased to introduce one of my colleagues in the medical anthropology field, Dave Citrin, who is joining us today from Seattle, where he is currently, and he'll be talking about his work in Nepal, where the two of us have actually worked in similar settings and or the same setting in Humla district at different points in time over these many years now. And so I just wanted to make sure that everybody knew that this is recorded, and we will make that the recording of this available through the speaker series website after the fact, if people want to share it with friends or other folks who couldn't make it. So Dave Citrin is an affiliate assistant professor in the departments of global health and anthropology, and directs the South Asia Center's Nepal Studies Initiative in the Henry M. Jackson School of International Studies at the University of Washington. He also serves as an implementation research advisor for Possible, which is an NGO that works in Nepal, but I'll let Dave talk about that later. And he's a research collaborator with Medic Mobile. Over the past 15 years, Dr. Citrin's work has focused on the ethics of global health and global health partnerships, designing digital tools and health information systems for care coordination and monitoring and evaluation, and also mixed methods implementation research to strengthen public sector healthcare systems. So Dave's, one of his special areas of expertise is in public-private partnerships. And because I wanted to invite people to our speaker series this term who did have experience kind of bridging the nonprofit sector together with ministries of health, I actually invited Dave specifically because of this experience and his ability to reflect in very concrete ways on what it's like to bridge those two kind of groups in the joint endeavor to improve health outcomes in the global health sector. So with that, I'll turn things over to Dave with thanks. So Dave, take it away.
Great, thanks. Can you hear me still?
Yes,
okay.
All good.
To share my screen. So hopefully go ahead and do this. Okay, can you see that? Is that working on full screen for everyone?
Yep, looks good.
Great, okay. Well, thank you for that introduction and for inviting me to be part of this lecture series. It's an honor. Wish we could all be there in person, but Zoom is our life these days. But yeah, I'm excited to get to share a little bit about the work I've been doing in Nepal. I admit that this is a talk that I've not given before and involves some new ideas and concepts. Some of it's based off a published paper with some colleagues, but some of it is still pretty new and kind of fresh ideas and therefore a little raw. So sometimes those make the most interesting conversations. So hopefully we'll have some time to dive in. I'm going to keep an eye on the time and try to make sure we've got some time for discussion and Q&A. So by way of an overview of kind of what we'll do today, I'm taking this chance to talk a little bit about the cultural politics of public-private partnerships in the field of global health, particularly through looking at one partnership in Nepal between the organization Possible that I work with and the Nepal Ministry of Health. I'd like to provide a little bit of context about Nepal for those who are not as familiar, though I imagine some certainly are. And I'll kind of highlight a little bit about kind of the recent trends towards the growing kinds of private services and privatization of the healthcare sector in Nepal. And I'd like to reference two specific pieces relevant to this story, which is the recent rollout of Nepal's national insurance program and a little bit about Nepal's medical education sector as well. And hopefully we'll have plenty of time to talk about two stories from my work with Possible that I think help highlight the kind of special, contested, and sometimes very fragile space of public-private partnerships within the healthcare sector in Nepal. Yeah, hopefully we'll also have plenty of time at the end for Q&A. So that's the goal. And yeah, so I'll dive right in. Public-private partnerships, I guess, kind of taking a step back, as many of you will know, are really a collaboration between a government entity, which is the public piece, and some kind of private actor or entity, kind of deciding to work together. Some of the larger ones on the bottom, these examples that you might be familiar with, are kind of PEPFAR, President's Emergency Preparedness for AIDS, President's Emergency Plan for AIDS Relief and Preparedness. That was inaugurated under George W. Bush. Gavi, which is the Global Alliance for Vaccinations and Immunizations, and the Global Fund to Fight AIDS, Tuberculosis, and Malaria. These partnerships tend to, put a lot of money into national budgets, particularly in low and middle income countries. They often result in kind of new forms of competition between different actors and entities who are kind of seeking these pots of money, put out through open calls for applications for projects. And also, have new forms of metrics and indicators used to kind of evaluate the success of these programs and kind of result in creating new kinds of accountability structures and in the effort to promote good governance within the healthcare system, working in collaboration with the government. In Nepal, this looks pretty similar, where these collaborations between the Nepali government and any combination of non-state actors, such as non-governmental organizations, the community-based orgs, bilateral development agencies such as USAID, universities and other academic research centers and philanthropies, etc. Nepal does not have an official policy on public-private partnerships. It has this kind of guiding document that was written in 2012 called Nepal's State Non-State Partnership Policy for the Health Sector. A bit of a mouthful, but this document essentially serves as the guiding policy document for PPPs, public-private partnership. Because Nepal has experienced a lot of political instability, there's been a lot of rotation of governments year after year, and so as a result, this document was never formally approved by any cabinet, but still kind of pointed to when these PPPs are arranged. One thing that I'm going to suggest today is that the growth of these collaborations and arrangements have really reconfigured the healthcare and public health landscape in Nepal. A lot of hope being poured into these arrangements that they will contribute to, tackling disease in a more robust way and overall supporting, the phrase that is often used and emerged around the same time as the public-private partnership language, which is healthcare system strengthening, which is something certainly Possible, the organization I work for, is trying to do, along with a lot of other organizations in that space. But these PPPs also kind of come with a lot of uncertainty, kind of taking ideas and concepts that themselves are somewhat ambiguous, such as public and private and partnership, and hyphenating them together to kind of create, in some instances, sometimes a more nebulous arrangement. But that sounds, good that we're all kind of collaborating to support this partnership to strengthen the national public healthcare system. And as I'll kind of argue, NGOs, in particular smaller NGOs, are often playing increasingly big roles in, being highlighted as, successes within the broader global health agenda. I think Possible is certainly got caught up in that, along with a lot of the other organizations in this space that we work with. I'd like to show this chart for some context in terms of giving a sense of what's going on with NGOs in Nepal. This is a new chart. I had an older chart that only went up to about 2015, but I checked recently, and this is pretty recent up until last year, that shows the monotonic rise of registered NGOs in the country of Nepal that are affiliated with the Social Welfare Council, which is the council that oversees and registers all the work of NGOs. You can see since the earliest times of registering, the late 70s, very small numbers, 1990, 1991, when multi-party democracy was ushered into Nepal, and kind of investment and organizations from outside of Nepal kind of brought in to be bigger players, and then up until fairly recently, where Nepal has cracked the 50,000 mark. I'm sure if you were to drill down and kind of look at how many of these organizations are regularly mobilizing funds and running programs, the number would be perhaps somewhat less, but let's call it 30,000 to be conservative. That's still a lot of NGOs operating in a space, many of them working in multiple sectors, but a large number of them working in the health sector. Title this slide, the kind of the struggle for Nepal's public healthcare sector. This could be a struggle about any other number of countries because, in such large numbers. I should point out this idea of, NGOdom. This is a phrase borrowed from the late Nepali anthropologist Saubhagya Shah. It's kind of a play on words where he's referencing Nepal as the once only Hindu kingdom and one of the world's newest federal republics, but kind of using this phrase NGOdom to point out that in such sizable numbers that the government ends up being kind of bifurcated, at least into the actual national government and the throngs of NGOs that kind of create a new kind of non-governmental government that people are really forced to navigate in terms of having access to education, food, healthcare, employment. As I mentioned, in the 80s and the 90s, Nepal started to liberalize its economy and other sectors as well, including the healthcare sector. So we saw, a pretty significant uptick in terms of private healthcare services. As mentioned, this non-governmental government creating all new kinds of hybrid projects, hybrid partnerships and collaborations, which over time kind of morphed into what have been called these public-private partnerships. But a number of other for-profit and private institutions, such as fee-for-service hospitals, clinics, nursing homes in recent years, for-profit and private medical colleges and teaching hospitals, which I'll also talk a little bit about, growing number of pharmacies and pharmacy shops, and a large number of informal practitioners, and I don't mean kind of traditional healers or even Ayurvedic practitioners who are part of the government system proper, but those who are not licensed, who are often referred to as quacks, or leading Nepal's government to actually have an Operation Quack in 2016, which led to kind of a large number of arrests and crackdowns on people who were practicing without formal licenses, whether that's nurses, doctors, or pharmacists. I think Kimber and I can certainly think of one very prominent example in the district, Humla, where she mentioned, and I think I saw some other Humla anthropologists and scholars on the call earlier, but there was one very high-profile case that made the news about a doctor without a medical license who was operating an NGO-run hospital for a number of years. By way of some other numbers, kind of just to look at the growth of what's going on in the sector. In 1990, there were 16 private hospitals. As of 2014, over 300, most centered in urban areas, many with it near the capital. Roughly 2/3 of all hospital beds in the country are private, and upwards of 60% of Nepali doctors are employed in the private sector, and this does not include those who are employed in the public sector who work after hours or moonlight in private clinics. Government health expenditure per capita in Nepal is 16 US dollars. It's not a lot, and kind of compare that to what's going on in the US at about $9,000 per capita. It's not the best example since we spend a lot of money on healthcare with some fairly poor population health outcomes, but you can look at countries like Sweden or Norway that spend about $4,000 or $5,000 per capita. And of course, the private sector accounts for a large number of total health expenditure each year in Nepal, and even more, about roughly 80% a number of years ago of total health expenditure comes from people just paying out-of-pocket payments. A study in 2014 found that 1 in 7 households in Kathmandu reported catastrophic expenditures on health in the last month. Catastrophic being defined as 10% or more of your total household's expenditure on everything going towards health or healthcare. So in an effort to address this kind of epidemic of out-of-pocket expenditures and the resultant medical debt and impoverishment that was happening, and in line with the United Nations Sustainable Development Goals, plans for pushing forward with universal health coverage, Nepal implemented a pilot insurance program in about 2015-16 that has now been spreading throughout the country as well. This is a screenshot from a promotional video that was circulating at the time that took a very famous Nepali actor, a serial soap actor, and used him to promote the Gajab Co card. Gajab means amazing, so this is an amazing card that you get when you enroll in the insurance program. The insurance program itself was a public-private partnership between the Nepal Health Sector Program, which is part of the ministry, the Korean International Cooperation Agency, and the GIZ, which I think might have changed their name, but this is the German development agency. And they were, piloting this and trying to roll out this insurance program and trying to promote it as something that everyone should enroll in. And the way they did this was having enrollment officers going door to door, registering households, where each family member would pay $25 with family up to 5 people. So it was about $25 buy-in for the promise of up to $500 in coverage at public sector facilities. And only public sector, not private facilities. So some bells and alarms should be going off here. It's been reported in the past few years that this program has been running in the red and just really struggling with the ability to sustain itself through raising premiums. I'll offer 2 potential reasons for that here. I think there are probably a handful of them, but one that comes to mind is that the private system and the private sector tends to be less bureaucratic. Even though it might be more expensive, it is more readily available. Most likely there is a private clinic or private hospital, depending on where you live, closer to you than a public hospital. Sometimes private facilities will give you more medicine, with still prominent idea that more is better. And then drawing on an observation that actually Dr. McKay and Dr. Catherine Sanders, a University of Montana grad, made a number of years ago, was that people tend to be frustrated by the hollow promises of well-trained strangers who continuously show up at your door, whether they are NGO workers, enumerators conducting household surveys, politicians promising a better life if you vote for them, or enrollment officers promising you, $500 tomorrow for the price of $25 today. So, these unfulfilled promises tend to kind of, raise the idea of something perhaps too good to be true, and kind of people tapping into their archive of experience and the public imaginary of what they've seen, makes them fairly suspicious of, needing to raise premiums off of poor people. There were sliding scales, to be sure, but of course that was challenged as well. So that's the insurance program. I want to talk a little bit about Nepal's medical education sector, which has kind of been pulled into this growing trend towards privatization and commodification of the healthcare landscape in Nepal. There are a few public medical schools, but there are 17, I think even closer to 20 private medical schools in Nepal. They all tend to be, as mentioned, either based in the district headquarters or in the capital proper of Kathmandu. Tuition ranges from anywhere from US $30,000 to $50,000 per year. So of course, a tremendous barrier for those in the most impoverished or far-flung communities. And it's also readily known that behind the scenes donations can help gain you access, and in some investigative journalism, much like the reports of quote unquote fake doctors, or a lot of high profile leaders in medical colleges getting kind of busted for boasting about how they could bribe the Secretary of Health or the Nepal Medical Council to gain anybody access to a seat in medical schools. The most prominent outspoken activist against this is Nepal's renowned Nepali orthopedic surgeon, Dr. Govinda KC, who has gone on upwards of 20 fast unto death protests against the medical education sector here in Nepal, arguing that the government needs to stop accrediting these for-profit and private medical colleges with substandard facilities and curriculum, that seats and medical schools need to be equally distributed throughout the country, and that they should not have people who lead these schools being, appointed by their friends who are politicians or other personally motivated appointments. And his followers and throngs of young medical students throughout the country are, actively protesting in support of Dr. KC regularly throughout the year, and have made some modest wins, but for the most part, this kind of remains untouched. The education sector kind of, again, perpetuating the idea that those well-connected, more well-off people are the ones who are gaining access to becoming doctors or buying their way into it through something a little bit more sinister. All of this kind of amounts to a far cry from what people are being told in their new constitution promulgated, it's not new anymore, in 2015, that is seeking to enshrine equitable and free healthcare from the state as provided in law. But this really jars with what people are experiencing, what they're seeing, what they read in the newspaper, what they hear on the radio, which kind of contributes over time to the kind of growing mistrust of a healthcare sector, of doctors, of people who are part of this at some level. So talk a little bit about the organization I work with now called Possible. We'll talk a little bit about the name in a second, but this organization was started in 2009. The goal was to really work within the public sector and strengthen the national system. So the idea was to work primarily within government facilities. So don't build new clinics, don't build new hospitals, but just kind of help revamp or top up and strengthen the healthcare system, and link these facilities with networks of community health workers, so that you could kind of have this continuum from household to facility care. Along with the government facilities that Possible was helping to operate, there was government financing. So in a fairly unusual, from what we saw, kind of example, the organization would be budgeted into districts' kind of red books, the official book that makes a budget. And we were receiving money in a kind of capitated per population financing mechanism. It's similar to like accountable care organizations in the United States. It's almost like, Medicare or Medicaid, where you have like populations of people whose overall, health outcomes will improve, and you kind of get a certain amount of money per person within a catchment population. So we had similar agreements with the Ministry of Health operating for many years. We had no non-Nepali providers working in any of our hospitals, something very strongly we believed in, because this was about building capacity within Nepal's government system, and any number of ethical complications around expats or non-Nepali people providing care, which we can talk about later. And really prime amongst our operating model was the framework that, or was the idea, it was this principle that patients should not pay for care, in line with the constitutional mandate and this push towards universal health coverage, that at the point of care, there would be no cost. This was for anyone who lived close to the hospital or who walked 5-6 days to get there. We were absorbing all of those costs, which we heard over and over again from people, fellow colleagues in the space, from the government of Nepal themselves, that we should probably reconsider this. This might not be all that sustainable. But that has been something that has persisted ever since. So Possible's goal was to really integrate primary care from the household to the facilities, focusing on reproductive, neonatal, maternal, and child health, high burden chronic diseases in the catchment areas we worked, and mental health, which had gone primarily ignored in the areas we were working. And while we were working as lockstep and as closely with the government as we could, we were also trying to innovate a little bit, such as designing a public sector open source integrated electronic health record system, and kind of doing some implementation science research to see if our model was working at improving individual and population health outcomes, and if we could scale the program and use some of the lessons learned and evidence we were generating to influence some of the national policy environment in Nepal. And that was a big part of the work I was doing with the digital systems team and our implementation research team. Some of you might know this. The organization Possible was originally called Nyaya Health. This Nyaya translates most readily as justice in Nepali. There are a lot of reasons, but ultimately the organization changed its name from Nyaya Health to Possible right around the time I was joining in 2013. As I said, a lot of reasons, but I think prime amongst them was Nyaya can be hard to pronounce. Often people would say Naya. Naya means new. Nyaya means justice. So it was this kind of fumbling with a name that we felt, the leadership and the board felt over time that if it's hard to pronounce, it's hard to memorize, it's hard to tell your friends and colleagues about, and ultimately it might be hard to fund. So the organization changed its name to Possible, largely because most people were telling us that what we were doing was impossible. And I think there was a little bit of gumption behind the board and leadership that said, no, what we're doing can be possible, and let's move ahead with that. The far west is the district of Acham, right here where the organization started in 2009. And then 2015 in the east, after the earthquake, this is the epicenter of the 2015 earthquake, talk a little bit about as well, we moved into working in the district of Dolaka. I'll talk a little bit about both of these spaces. This is Bailpata Hospital in Acham. This is the photo taken by the founders of the organization in 2008 when they went out to see what was going on in this district. They actually went to make a documentary about the kind of growing HIV and AIDS epidemic in rural Acham at the time. The founders were 4 med students. 3 of them were born in the US. 1 was born in Nepal. These were all students. They were residents at Harvard Medical School, students of Dr. Paul Farmer, which I'm sure some of you will be very familiar with, who's prominent and kind of leader in the social justice and global health movement. So there you can kind of see some of the roots of Nyaya as well. It's kind of justice in action, justice through health, kind of became the name of the organization. And, fast forward to January of 2020, this is Bailpata Hospital now, completely revamped. So as I said, we work within government facilities. This is kind of that example of, well, how close are you to that mission when you are kind of knocking down infrastructure and building an entirely new building? Local materials, local workers, earthquake resistant, rammed earth construction, solar power because of the challenges of the grid, really cool stuff. But, it does raise the question of how scalable. I mean, the idea was never to go and build all of these kinds of hospitals, but, in a remote part of the country that didn't have kind of a high quality tertiary full spectrum hospital, we wanted to kind of provide that. And of course, we were very proud that not only the hospital workers and everyone who worked with the organization, but that there was this really nice facility that people could present and seek out care, and it made both providers and people who came to the hospital feel like people were paying attention to them in this remote district, and it kind of brought, as I said, a great sense of pride amongst those who showed up and had this really nice place that they could kind of feel inspired and honored to do that work. Wasn't all at the facilities, as I mentioned. We're kind of linking community health worker networks to make sure that CHWs could be this frontline referral touch point for people, counseling people at their houses, following up on medication, just being a line for people to reach out to. These are not Nepal's renowned female community health volunteers. This was a different group of community health workers who were paid as full-time employees because Nepal's community health volunteers were not paid. But we, hired, in a very similar model, hired networks of community health workers who all lived within the villages where they worked, visited each household once every 3 months, followed up on chronic diseases, referrals, as I was mentioning. But again, it raises another question of creating a somewhat parallel system when there already exists a community health worker model. Each have their own kind of challenges. We can also talk a little bit about that as well. Community health workers were fully involved in kind of real-time data feedback loops using our integrated electronic health record system, involved in kind of data review, kind of being really the eyes and ears of the organization, and really comprising not only a human resources backbone, but really at the center of the analytics backbone and kind of collecting data at that community level that we could use to measure and evaluate the success of our programs. So we had data streams that were linked up at the community level with facility-based electronic health records. And for lack of time, I won't dive too much into this, but happy to talk about our integrated EHR if anyone has any questions, which we also tried to kind of create with the government. So we kind of had an open source platform that could, work for government reporting, monitoring, evaluation, longitudinal patient care, quality improvement, implementation research. So, we made some modest improvements and some outcomes in ACHAM, institutional birth rate, reducing neonatal and under-2 mortality. And we were still very humble and a little bit skeptical of our own work at the same time, but after the earthquake happened in 2015, there were 2 large earthquakes, and dozens and dozens of aftershocks over the course of months. But this one that happened in May of 2015, Possible was invited to recreate a public-private partnership in Dolika, which was the district to the east, kind of in a similar image of what we had been doing in ACHAM. Same community health worker program, kind of topping up and helping to kind of co-staff with government health workers, our NGO paid healthcare workers at this facility. So that we did not build this. This was already built before the earthquake and actually suffered very little damage, maybe a few cracks in the walls. But Médecins Sans Frontières, Doctors Without Borders was working there right after the earthquake, and they kind of were eagerly asking for they're not there to stay, so they were really looking for someone to come in and take over. So the government invited us. We were unsure if we were going to stay. This was not something in our plans. We didn't think we were going to, scale outside of the one district where we worked. We had a lot of, challenges still going on there. We were really interested in refining the model in ACHAM and trying to see if we could continue to improve that. But this represented an opportunity to, at the invitation of the government, to see if we could do something similar in another district. So we took up the challenge.
Dave, I was just going to jump in and give you about a 10-minute warning until Q&A.
Yeah, I saw that. Thank you. We'll see if I can get to my second story, but this first story should give us plenty of things to talk about. But so we've been working in Charikot for about a year, and following the earthquakes, and things were moving pretty smoothly. However, the districts were very different, right? ACHAM was in the far west. There was another district hospital in ACHAM, but there weren't a lot of other private clinics, and there certainly weren't other hospitals. Dolika, being much closer to Kathmandu, having a much more bustling and large district headquarters, had a number of private clinics, a number of private hospitals, with investors and trade unions who actually stood to make quite a bit of money from people who were seeking out care. Modest as each, outpatient booklet might, or registration ticket might cost, that was money that they were making. And so this NGO kind of rolling up, taking over the district hospital and providing free care to anyone who wanted it, whether inside the district or outside, was pretty problematic. So fast forward a year later, and we had a tragic incident where a young child presented with dehydration and diarrhea in the afternoon, I think on a Friday, and later that evening passed away in our hospital. This was the child of a fairly prominent and well-off family member within the community, and within hours, the hospital was surrounded by protesters. Just this is not a picture of that, but you can just picture however many people there times 10 or so, just thronging around the hospital. Cars, motorcycles, everyone pulled up, chanting, banging on the windows, many holding gasoline canisters with lighters, threatening to burn down the hospital. Some went into the hospital, assaulted our nurses, our doctors, physically, ransacked their living quarters. Many staged tableaus of, they found beer bottles, and they were kind of positioning them next to stethoscopes and taking videos of people's quarters, really trying to just give the organization a bad name. And posting it on Facebook and YouTube just immediately. It was just circulating immediately, and it was national news fairly quickly. The government, the police came and tried to protect our government healthcare workers. Eventually they said, we can't protect you, you have to try and get out. So a lot of the healthcare workers kind of jumped off the back and kind of ran off into the woods until this kind of died down for that evening. The next day, same thing, a day or two, just continuous protests until it led to some political cartoons that popped up in the day or two following this incident. But here's a screenshot of a video that was kind of this forcibly extracted apology and admission of guilt by some of our healthcare workers. On the front steps of the hospital, you can see the police there kind of providing some protection. And the hospital was shut down for several days as this was all kind of being navigated. Of course, that meant everyone in the hospital had to be discharged despite their condition and despite the certainty that whatever care that they were going to receive after that was going to be paid for, or fee for service. But that was kind of what transpired in Dolica. And I bring this up for a few reasons. One is to kind of highlight the tenuous position of a public-private partnership at a moment that caught us quite off guard. A lot of things broke down in this moment, right? The partnership between the government, who was totally kind of MIA during that time, just unable to contact them. If this is a government facility staffed by government healthcare workers, of course many NGO workers as well, it was kind of a 50-50 split at this time. Is it a public facility? Is it a private facility? Does the government step in? Should they not step in? And discussions kind of with trade unions and some of the investors and representatives from these private hospitals kind of transpired over the next few days. And what we would hear over and over again, and this was kind of reported from our Nepali colleagues, was saying these people were livid. They just didn't believe us. They said, there's no way you're not making money off of this whole thing, meaning the hospital, the public-private partnership. NGOs don't provide free care. It's just not something they did, And in Nepali, they were saying, like, where are you hiding the money? Don't tell us these things. Like, we know you're profiting off of this. So there was this real sense that, the kind of like the national insurance program, this promise of free care is just a little too good to be true. Someone's making money off of this, right? And over the past, I'd say, year, this hospital has been fully transitioned to being operated by the government itself. So a lot of changes, a lot of upheaval, a lot of trying to make sense of what has happened there. We're still working through it. I see I've got about 4 more minutes. Do I have time for another quick story, or should I stop here? What do you think, Kimber?
Will it be about Acham?
It'll be about Acham. Yeah.
Go for it.
So this is kind of going back to Acham, which is the flagship hospital that we built, and different context, but the same organization, same stuff going on. But this is another just wrenching story that I think we're still trying to make sense of. But long story short, as you scale your programs and you try and scale your operations, you still need to generate more funds, or at least the same level of funds. This was something over time we struggled with, to be able to continue to get those grants, get those philanthropies and those charities to reinvest in you. It's a lot of work, but we over time weren't able to continue to operate at the same budget, which led those of us in the U.S. To kind of be in touch with our colleagues in Nepal and say, there's $1 million less this year in a budget, right? We all have to kind of figure out what to do with that. This is all happening at the same time as like those of us in the US are trying to make sense of what is our role, particularly during this moment, this very salient moment of decolonizing global health. Like those of us who, helped kind of build this, and how do we find our counterparts to replace us, or how do we just move into thought partners, and how do we stop making decisions? How do we seed decision making over budgets and the vision for strategy and research and all this stuff, which we've been in the process of, which led us to step back from things like hiring and firing and decisions about promotions and all of this stuff. Of course, we then couldn't raise all the same amount of money, so when we said we're about $1 million short in budget, our Nepali colleagues had to make sense of that and started to remove perks, professional development opportunities, Jeep rides, looking through who might be able to be retrenched or laid off, right? This was not something that those of us in the U.S. were, participating in, much to our dismay. But we really kind of had to step back and say, if this is what stepping back looks like, let's really step back and trust that we have the right people in place, and we've created the right context where people can see their way through this. What started happening was people were being laid off. And one colleague who lived very close to this hospital that you see here is from the community, quote unquote, low caste health aide, who's responsible for cleaning the hospital and making sure it was in tip-top shape. He went to the front of the hospital in the middle of the afternoon and set himself on fire and self-immolated in front of the hospital because he was going to lose his job, based on this kind of putative notion of performance reviews that weren't up to snuff, or so feeling perhaps like he had no other recourse, a quote unquote low caste person, maybe not seeing other options for jobs or school or employment, took this drastic and tragic action that also of course made national headlines. And of course the story was the international NGO unable to raise funds, worker kills himself, something along these lines. There are no fingers to really point at any one direction. If any direction, they need to directly be pointed at those of us in the US who did create this situation. But all that is to say, as I see we have 40 minutes, that these public-private partnerships are incredibly tenuous, even when they are unique, novel arrangements that have the support of the government and that you think you're doing the right thing, and are trying to make the best of changing circumstances. We found ourselves in this scenario. All that is to say that we are actively still working through this. None of us are over it, nor will we ever really be over it. But I think we're in a real reckoning right now, which is, as I mentioned, what does global health look like, after decolonizing global health? Should it survive? Did possible not survive, and we just don't know it yet? Some of these questions that we're really still struggling with. We're just in it. We're stewing in it. So even though we've done some really good stuff and are proud of a lot of the work, I think we're really also still trying to make sense of what this looks like moving forward. So I'll stop there because I think we're right at 40 and open it up for any comments or questions. And I'll pass my slides. I'll pass my slides along to you, Kimber, so you can share them and all the references here as well. But there's my email if anybody wants to.
Excellent. Sounds good. Thanks, Dave. And thanks so much for sharing those stories. And, I know especially the the last one is tough to talk about and obviously sensitive for a variety of reasons. But I think that just really highlights the complexities associated with doing work in the global health sector, where I know that the work that you did as a critical medical anthropologist from day one was laying the foundation for an appropriate and careful exit or handover, phase out, whatever you want to call it, to the government, which everyone in the sector recognizes is, or I think is beginning to recognize, is not only essential, but ethically appropriate. But despite the work that you did, as you described, things didn't kind of unfold as planned. And so thanks. I know that's everybody wants people to talk about failures or mistakes made, and not many people have the courage to do so. So that's that's tough. I wonder if people might want to unmute themselves and ask questions or post questions in the chat next.
Hi, Dave. This is Catherine.
Hello.
It's good to see you. I was just wondering, since the last time we touched base, there have been a lot of similar sort of things going on with my work in Kenya, and I'm wondering what your thoughts are on what needs to be in place, like what needs to be in place before this kind of handover can happen successfully, given your experiences.
Yeah, thanks. That's a great question. I think that is the question. I certainly don't have the answers, but I can respond with some of the things we're thinking through. I think prime amongst those is the idea that it's really important to design within the constraints of the government system, maybe even early on and a lot earlier than we thought. I was talking about innovation, and we're trying to be always maybe a little bit ahead of the curve to try and push on some policy environments and see if you can kind of influence the ministry or even just within the district policies. That led us to do things like create patient navigator programs, which is like cool. It's cool stuff, right? Every facility in any country should have a patient navigator program, someone to help people navigate the incredibly complex systems of healthcare that we all do. But that's not a cadre that exists anywhere in Nepal. So if you're thinking about scalability and handoff, that question of will the government be able to take on this group of workers, right? Or will they be let go? Or will they start a new cadre of patient navigators, and start training them throughout the country, right? The answer was no. Same with, our electronic health record system. There are no EHR engineers throughout Nepal, right? So we built a whole team of people who were never going to have a full-time job within a government system, right? So it's this idea of, if you're designing for like scaling within municipalities within Nepal or any country, it's what does that system of municipal care or district care look like at quote unquote pure government level, right? Everything from funds to what the staffing looks like. Arguably, the whole reason we started this was like thinking that we needed to top that up or innovate or improve around it or support it. But one thing we learned really was if that buy-in isn't there every step of the way, like inevitably you're going to run up against these hard surfaces and these decisions about, what can really be it's a terrible word. What can be, given up in this transition to a government or as you kind of hand it over. So I think we really, we're thinking more along the lines of if you innovate and build it and it's cool, they will come, they will come and they will fund it, which didn't necessarily pan out. I think that's one piece that we learned for sure. And then I think the other one is this idea of a durable revenue source, right? We had this very unique model, which we actually thought was sustainable, where the government was the regulator and co-financer of the work we were doing. And that turned out to be pretty fragile as well. And in fact, once a new minister of health and a secretary of health came in and they said, wait, that guy was from that party and he was doing that. Well, I'm from this party and I'm certainly not doing that, right? I mean, we see this here in our own country, right? New administrations coming in and jettisoning plans and policies from a previous administration. That happened. And alongside of that went out the window, part of an operating model that we thought was really kind of robust. So there's some stuff that I think we could have planned for, kind of the like designing within the constraints and making sure that buy-in is there, lockstep all along the way, which of course, as you know, is very hard with turnover in any country, not just Nepal. But and then I think that idea of revenue and partnership, and are those things, just because you have this piece of paper that's signed with an MOU, are those things kind of commensurate and sustainable or durable? Will they last? So yeah, we should definitely connect, and I'd be happy to and chat more about this. But those are just a few things that come to mind that I think were lessons that we learned along the way, maybe a little too late.
Thank you, Dave.
I think we have time for one more question if somebody wants to unmute and ask a question.
Hi, Dave. This is Lee Taggart. Can you hear me?
Yeah, hi.
Okay, hi. Thanks for your presentation and talking about your challenges. Impressive. I guess my question is, where do, I work for a couple of NGOs, one in Uganda and one in Morocco, and where do we fit in with supporting the government or working with these governments to be the role model, to be there for their people, to be able to support programs and be consistent, like your dilemma with different governments coming in, changing the plan. Like you say, who are we to talk in some ways here in the United States? But I guess my question is sort of like, how can we play a role in supporting that or being good role models so that these things don't happen?
Yeah. Oh, I mean that's the question. I think I don't want to say that, as like Kimber and Catherine and others know, a lot of my early work was talking about the perils of foreigners getting involved in, healthcare in remote places like Nepal, or kind of what I would call medical volunteerism, and that very short-term engagement. And, as Kimber was saying, that shaped a lot of my thinking around this work with Possible, which is, if you're going to do this, commit to the long term, commit for the long haul. Know a place, know a language, know a region. Find the best way to help by putting your ear to the ground and listening to people who, maybe are giving you guidance on the best fit for you. Sometimes that's not, putting your ear to the ground produces cacophonous sounds, but I think one thing I don't want to say is, we should all just go away and, leave government healthcare systems in low and middle income countries to, not have any support. I guess my question is, what is that for myself, for all of us, is what does that support look like? As you said, I think it would be irresponsible to say those of us in wealthy nations historically have contributed to the under-resourcing of healthcare sectors and systems in low and middle income countries. So we're just going to step back and just good luck. Now it's off to the races. Hope we're not going to get involved anymore. I don't think that is ethically the right thing to do either. But one, in this current moment where global health is still a field, where very few of us in the field of global health, I imagine, I don't know this for a fact, but very few of us have been traveling around in the same ways we used to pre-COVID, and governments have been, in some ways, dealing with the pandemic, dealing with healthcare system strengthening efforts, not by themselves, but in an entirely refashioned way. I think there is a pressing question for us to say, what do NGOs and what do INGOs involve? What does the involvement look like as we think through this decolonizing global health movement? Excuse me. Does it look more like just fundraising? Does it look more like thought partners to people in the countries where we work who are ultimately the ones making the decisions? Does it look, I mean, these are some of the questions that I just don't have the answers to, but I think there has to be some model of accompaniment where we take our cues directly from the government, and as frustrating or challenging as it might be at times, we really just stick to national priorities as they are laid out. Because if we don't, and I'm speaking again from the experience in Nepal, we may find ourselves all of a sudden kind of out in left field thinking like, well, we thought we could just kind of lead that government horse to water, so to speak, or, but, being ahead of the curve is not necessarily the right thing to do. Sometimes it is, what are the top 5 national priorities of the Ministry of Health in this country? And how do we make sure everything from writing papers about it, to applying for grants, to having meetings, has some representative from that government body, right? I can't tell you how many papers that we would write at Possible, and they'd be real close to being finalized, and we reach out to a ministry partner and be like, hey, would you like to be a co-author on this? And a lot of times they would say yes. But my favorite government officials were the ones that were like, no, you already wrote this paper. If you want my involvement, invite me at the very beginning when we're talking about the topic, and I don't want to be a ghost co-author on this. That's the stuff that's like, the buy-in is from the beginning is really important every step of the way. So I don't have the answers, but when we create technical working groups, when we create research units, when we write papers, when we create strategy, having that buy-in as early as possible, and like real sincere relationships that kind of go the distance and kind of endure through time, I think is one way to help at least protect against some of these challenges and kind of being caught off guard. But it's not a very satisfying answer. I apologize. But
Well, these are complex
No, that's
issues.
good. That's
Sorry, Lee.
Yeah, super complex.
Thanks for your question, Lee, and
No,
Dave, for
I
that.
just was saying thank you, and
welcome.
Everyone's trying to thank you at once, Dave. Thanks again for those remarks, and especially the answer to Lee's question, which is, I think, the question of certainly the hour, if not considerably longer. I think the decolonization of the global health sector is definitely the frontmost challenge that the sector is facing at this point in time, and something I know a lot of people are struggling with. So we'll have to wait and see what kind of scholarship and practice emerges from those struggles. I think we'll have to close for today there, with thanks to you again, Dave. And I'll just announce our next lecture next Monday at 2. This is a presentation, or will be a presentation, by 2 of our PhD candidates in the School of Public and Community Health Sciences. The first presentation will be by Juthika Thakur, who will present her work exploring the role of non-physician providers in improving the human papillomavirus vaccination rates in Montana. Sorry, I almost always say HPV. And so Juthika will be talking about her research into that. And second, we will have a presentation by Jaid Hassan, who will talk about his work with ICDDR in Bangladesh. And his talk is entitled "The Role of the International Center of Diarrheal Disease Research, ICDDR, Bangladesh, in the Fight Against Childhood Diarrheal Disease." So we have that to look forward to next week. And with that, we'll close the session for today. Thank you, everyone. As always, the recording will be posted on, of today's presentation, will be posted on our seminar series website, and we hope to see you next week. Thank you.
Thank you, David.
Thanks, everybody. Bye.